If you have any questions during the lecture, please write them in the chat box and we will ask Ms. Leininger at the end of the MCQs. We will offer 3 Viva spaces this evening, so please put in the chat if you would like to take part, and we'll select the first 3 candidates. The Vivas will not be recorded, and this is an excellent opportunity for you to practice answering your questions in a mock Viva format. For those people that are interested, we do run several courses throughout the year, including our intensive mock Viva course and our 2 new courses, which are a case-based discussions course for orthopedic exams and a basic sciences course, which we've just started. All the details and booking can be found on our website, orthopedicacademy.co.uk. This session will be recorded and will be available on our YouTube channel in the next few days, so don't panic if you miss part of it or you want to revise it. Our invited speaker this evening is a consultant orthopedic surgeon in the northwest of the UK, and he's a member of the Faculty of Surgical Trainers of Edinburgh, an honorary senior clinical lecturer at the University of Liverpool and Edge Hill University. So it gives me great pleasure to introduce a dear colleague and friend, Mr. Kartik Iyengar. Thank you, Kartik. I'll just stop.
So shall I share?
Yes, please.
Hi, hi everyone. My name is Kartik. I work in a place called Southport. Originally, I'm from India. So welcome to everyone here in the UK and across the world. So today I'm going to talk on non-union of fractures, and we'll talk a bit briefly on bone defects. It's an interesting topic. I like it. It is the Viva table I take in my FRCS Viva courses, and let's take it from there. So the learning objectives we'll try to look at today are these. We'll try to define what's a non-union. We'll try to look at the classifications. How do we evaluate non-unions? What are the options of treatment? Algorithm, I've made my own, a brief one, albeit so. Then I will discuss some cases, and then we can have a chat about it. And then I have put up a slide where you can have some reference articles if you want to look into it. So let's go to what is a traditional queries in a talk. So what is a non-union? That's what I want to know. Why does it happen? What are the risk factors? How do you classify them? And how do you, when you have diagnosed non-union, how do you go about managing it? So we will look into all of this. So these are a couple of cases I want you to think about while we go through the talk. We will discuss this in the end. The first one is the 8-year-old with the background history of diabetes. And she fell, which is a common fracture nowadays, is a distal femur. And you can see the fixation, and obviously you can see the non-union there. And so the thought process is, how do we manage this? The same, this is a bit more complex. As patients live longer now, we are getting all of these complicated problems. But here there is a further complication. The patient has a failure of implant, infected non-union, and therefore, what do we do? So we will have a chat later as to how we can process these conditions. So looking at the definition. So when I ask my candidates, there is a couple of definitions they do, but these are the 3 which I have found consistently that I think we should refer to. So the FDA in the USA has defined a non-union as a fracture which is at least 9 months old and has not shown any progression of healing over 3 consecutive months radiologically. Clinically, it's a symptomatic fracture with no apparent potential to heal without intervention. So the two words are important here. So it's a symptomatic fracture and it's unlikely to heal without surgical intervention. And the other commonly used definition can be it's one which takes double the amount of what is normal for a fracture to heal. But if I ask you, okay, define what's a definition, the upper two are the ones I'm looking for. All these have traditional risk factors. These are quoted extensively. We all know about systemic factors, including comorbidities. I'll come to that. And most important is when you're managing non-union is looking at the local factors. What's the type of fracture, personality, was compound, open, was the fixation adequate or not? When you manage, is there a bone defect? How do we address a bone defect? What's a bone critical bone defect? So we will look into it. Most importantly, don't forget the neurovascular structure and the soft tissue. This will all come as we assess the patient and have devise an algorithm. How do you manage these patients? So there are multiple comorbidities. These are the 5 I want you to look into, because this for a higher order marking in FRCSO for 7 and 8. It's not just good enough. Oh, yes, the risk factors are diabetes, smoking, etc. I want you to understand why diabetes patients are at a high risk, why smoking is a well-defined factor. We need to look at microscopic level, biological level, why it can do. So let me expand on few of this. So this is diabetes. So if the person asks you across the table, okay, diabetes is a risk factor, I know, but please explain and highlight how this happens. So traditionally, patient with diabetes, these are the mechanisms how it leads to risk of non-union. You need to talk about age, you need to talk about ROS, and most importantly is that it initiates a process where patients are at a higher risk of osteoporosis. They have a lot of free radicals at the fracture site, which are not conducive to healing. In fact, they have significant amount of inflammatory mediators. And as you all know, these all patients are at an increased risk of infections as well. So that adds to the spectrum of non-union. So there's a reference I've quoted at the bottom. If you look at it, patients who have diabetics have 3 times the incidence. So that's the number you need to quote. That's 3 times likely for having non-union, delayed union, or wound complication. In fact, it has a 7-fold increase risk of increase in risk of hip fractures, and more about 1.5 times in type 2 diabetes. Let's look at smoking now. Same mechanism, similar mechanism, but the same structure I'm trying to elucidate here. Smoking, predominant is the relation is vascularity. Nicotine is a vasoconstrictor. It increases the local carbon monoxide levels. It counters the antioxidant properties of vitamin C and E. And this all leads to an environment which is not conducive to bone healing. It also affects the preliminary stages of fracture healing itself. So if I quoted a couple of references there, those are, I would suggest, take home, read them. There are 2 systematic reviews. One is by Bridget Scammell, you will know, from Oxford. And characteristically, if you are asked, okay, what is the risk of smoking-related non-union? Should I be able to quote this 1 or 2 of these papers? Say, okay, it's twice more likely to have non-unions, 2 times more, especially in tibia and long bone fractures. Vitamin D is another component, and how, that's what we need to learn. We need to understand vitamin D acts at all levels of fracture healing. That is the 5 levels, whether it's at the inflammatory stage, hematoma stage, formation of the soft callus, hard callus, and even remodeling. And also, vitamin D is important from wound healing point of view. So these are the 3 key factors and risk factors I want you to understand a bit, develop a bit more info on it when you are across the table in a Viva situation. Let's look at the concepts. So there are few theories and concepts as to why non-union happens. Uh, I'm sure you guys already must have read about Perrin's theory and Wolff's theory, but what I'm going to focus on a couple. The theory of mechanobiology. So union is an interplay between biology and mechanical stability. For the fracture to heal, both should work in tandem. If one of them is missing, this relationship is disturbed, and hence, this is the concept that one expects you to know, a theory of mechanobiology. However, at the FRCS or level, this is the concept everyone keeps talking about. Diamond concept is the concept of two people. So if you need to know two people in the world who have done extensive work on non-union, is these two people. Giovanardi's professor from Leeds and Professor Calori from Italy. They devised this concept as to look out for what are the reasons that the fractures heal and why these elements are critically important in fracture healing. If you look at it, it has got all the four components. It's got three biological components and one feature suggestive of mechanical stability. So the biology, and if you can look at the figure on the right, stem cells, these are essential for osteogenic. Matrix, organic matrix is important for osteoconduction. And growth factors, which are important for osteoinduction. So remember, these are the three key criteria which we use while we are talking about bone grafts as well, isn't it? So that therefore, these three key factor biological elements, but supported by the importance of mechanical stability. That's what it comes with fixation. But the biological three factors are important for fracture healing. The significance of this is what they feel as they develop this concept is for a fracture to heal, you need to have all of these working in tandem. Deficiency of one or the other uh, or a combination of other leads, and it's a risk factor for non-union. Let me show you for the other one. So though the biological concept of diamond concept was initiated in about say 2008 or so, this has been rightly emphasized now with the pentagon regenerative concept. What it is trying to say is, I think, why vascular supply is key. So apart from the four elements of the diamond, the element that has been included now is vascularization, because that's the key element where the blood supply, all the elements that are required to achieve healing are initiated. So here, this pentagon concept is the current concept that we need to quote. Diamond is good, but pentagon is a step further than that. Looking at classifications, so these are the two classifications I would like you to quote across the table. Everybody is aware of Weber and Scheck, but non-union scoring system is the hot topic. So let's talk about the traditional one. So this is a traditional classification we all describe. However, we are talking about hypertrophic atrophic here. And this was discovered and developed by two surgeons, Weber from Switzerland and Scheck from Prague. They looked at X-rays, and this is basically a radiological classification, looking at the biology at the ends of the bone. So if you can see on the left, it's hypertrophic, and the right is atrophic. How is this relevant? Classically, hypertrophic non-unions show a lot of bone formation. However, the key problem here is mechanical instability. Hence, if you fix the mechanical instability, the fracture should go on to heal. However, on the atrophic side, the element that is missing is biology. There, mechanical stabilization won't help. So you need to induce bone formation for achieving the healing. So why do we need a new scoring system? We traditionally widely use Weber and Scheck hypertrophic atrophic, very easy to describe. What, as with any classifications, there were factors which needed to be improved on the old Weber and set. Classification are necessary for you to communicate across, and therefore these had to be strengthened. So this concept of new classification came into in about 2008, 2009, around that time, and also again by two people, Professor Giovanardis and Calori, and they have emphasized the three key elements that are required. So one is the bone, the soft tissue, and third is the patient factors. So let's look at these. So this is a busy side, but this is what I could get. Very good article. Please refer to it. So they mark and give marks or score each element that patient are assessed in. This includes clinical examination, imaging factors, patient, the general itself, ASA grades, etc., and also what is the scoring of the patient and X-rays on Weber-Sec classification. All of these are scored, and you come to a number. When you come to a number, they are again reclassified into 4 groups. And one slide I would like you guys to take home is this, because this makes your algorithm and management quite straightforward and understanding it. So if after the NUSS scoring system, a patient scores between 0 to 25, it's a straightforward non-union, similar to the hypertrophic one. And if you improve the mechanical instability by revisiting the fixation, the fracture should go on to unite. Second one is the middle one, where both biology and mechanics is at fault. These patients are scoring between 26 to 50. So along with improving the mechanical stability, you have to induce biological stimulation. This could be due to various modalities. You can use pulse electronic magnetic field. You can use extra corporeal shock wave therapy, or the traditional biotechnologies like BMP, growth factors, etc. and etc. When you come to the third group, that's where it becomes a bit more complicated. These patients have both mechanical and biological insufficiency, but along with this, predominantly these patients tend to have infection. With this, they have a problem of bone defect as well. So you have to manage multiple things here. You have to manage the patient, you have to manage the fracture, but along with this, you have to manage the infection. And then after you have taken or resected the part of infected bone, you need to start understanding how you are going to organize the bone defect to be filled. So there are various methods where you can apply to achieve the bone defect mechanism. You can have bone transport mechanism. Mascele is well talked about. And the newer one, which I think is being talked about, is the RIA system. Reamer irrigated aspirator works well in femur, not much in tibia. And the traditional biologics, which are the scaffolds, growth factors, and etc. Coming to the fourth one, if a patient is scoring more than 75, the patient is host type C. In that, they have significant comorbidities. Patient's condition, local and general, is very poor. The size of the defect is so large that trying to undertake what we could undertake in the third group is literally not going to work. So probably they are the candidates for amputation, arthrodesis, or consider a complete resection and use a megaprosthesis. After you have diagnosed or classified, how do we assess radiological union? So this is the first article, which was by Bhandari et al., where they established a scoring system to evaluate union across tibial fractures after internal fixation. So they scored, they again had a point for scoring to assess three-dimensional healing. So if you look at bone as a three-dimensional concept, it has got 4 cortices. So if you see no callus in any of the 4 cortices, then you get 1 point each. So you can have a minimum of 4 and a maximum of 16. If you look at the second figure, there is some callus seen, but you can still see the fracture line. So they scored 2. If there is a bridging callus, but the fracture line is slightly still visible, again, it's a similar score. If you have a fracture which has healed with bridging callus, no fracture line seen, that is 3. So you count and multiply this with all the 4 cortices and look at whether the fracture is healing. I have recently looked, this is being applied to humeral fractures, this is being applied to femur fracture. Article got published last week. Please have a look. So people have started to extrapolate the RUST classification score, fracture scoring union scale into other fractures, humerus, femur, and probably this will come more and more popular. How do you assess patients? Apart from your traditional ways of looking or assessing a patient, of look, feel, and move, looking for scars, sinuses, feeling for pain, obviously for testing mobility. Always check for joints above and below, because this has an effect on management of the field. Neurovascular, don't forget. But these are the 3 percentages that you can quote, and the sensitivity and specificity of each of these factors. You can look at inability to bear weight carries the significant clinical way of judging by taking an history, and tenderness on palpation is about 35 to 40%. Imaging. I can give a whole talk on imaging for fracture healing and non-union, but I made it concise as to what are the traditional modalities of these. All the modalities have their own place in evaluation of non-union. Plain radiograph, the commonest one, the first one, it gives you the whole character of the fracture story, fracture journey, that it's good. You can know what was the type of injury, you can know how was the pattern of injury, you can look at the healing effort, callus formation, previous implants, how they has gone. However, more and more CT is being used to evaluate bridging callus. Especially, you can apply maybe extension of the RUST classification. It is useful in looking at patients who have hardware, near intraarticular fractures, looking at rotational deformities and limb length discrepancy, because this is common with infected non-union. You get that. MRI has not that much role, but it's used more around joint replacement, other thing. PET and scintigraphy is significant in that you can look PET CT using glucose, looks at the metabolism that is going on around the non-union and fracture site. And apparently it is useful in knowing the level of resection when you want to go in. So if you do a PET scan, you can look at the metabolic activity and know where the activity is there, where there is none, and probably can mark your level of resection rather than under resection of the fractures. So this is a ladder which I keep in mind when I have been given an X-ray or something to debate. So first, classify, define non-union, confirm why it is non-union, and describe the X-ray or the pathology. Then decide. Most key I would suggest is to know whether it's an infective or a non-infective one. Apply your NUSS criteria. Then you have an algorithm. And obviously, if you have a bone defect coming into the level 3, then you will know what other options that you need to talk about. You anticipate what are the questions that is going to. So this is one other key element that I think you need to keep in mind. So polytherapy is when we combine all the fundamental principles which we have in our armory, including which involve the diamond concept. You need to get your scaffold factors. You need to get growth factors. You need to get osteoporogenate. So all this, including the mechanical sterility, is called polytherapy. Usually, traditionally used in the third group between the 51 to 75 scoring on NUSS. Let me talk briefly on bone defects. I've not put many slides of it. The key here element I wanted to learn when I was reading about is the concept of critical bone defect. So you have a bone defect if you have an infected non-union or a non-infected one, but how do you classify that? Which bone defects should you maybe autologous bone graft? Which do you need some larger techniques or vascularized fibulas or not? So this is a definition commonly asked: critical bone defect. So what's a critical bone defect? It's a defect where after resection or after non-union that you are left with a gap, and if you leave it as that, it's not going to heal. So if the definition is passed, however, I have found out any gap non-union that is more than 2.5 centimeter is called a critical bone defect. So if you have a patient who has a non-union, whether infective or non-infective, and the gap is more than 2.5, then surgical intervention is required. I looked at a bit more to look at traumatic bone defect classification. This is a new one that has come back. Very nice classification is given, makes things very clear. So if you look at the incomplete defects, these are less than 2 centimeter. They are unicortical or bicortical losses. And as we go on to defects which are less than 2 centimeter with some deformity and obliquity of the fracture site, they are D2. But the critical one that is difficult to treat are the treatments where this critical bone defects is more than 2 to 2.5 centimeter. You can have some which are less than 4. Major are when they are between 4 to 8 centimeter, and massive defects which are more than 8 centimeter. Why do we need to do that? Because you can plan the management accordingly. If it is a massive defect more than 8 centimeter, then probably you need distractant or osteogenesis. If you have a defect which is 2 to 4 centimeter, maybe you can get away with Mascale or a vascularized fibular graft. So this is important. First, establish whether the defect is critical or not, and if it is critical, start thinking whether you need to do something else about it. So that's algorithm. Again, I keep coming back to algorithm. Define non-union, establish whether it's infective or non-infective, decide whether you have a bone defect which is critical or not, and depending whether it's critical or not, you can do traditional bone grafting, or if it is critical, then you need some more instruments in your armamentarium. So again, challenge infective bone graft is a different topic altogether. Significant challenges, including diagnosis, knowing the organisms, imaging strategies, completely different spectrum of this. Again, I come back to this slide. Learn biology. For the fracture to heal, not to go into non-union, need to have two concepts. One is the biology, second is the stability. So if you need the biology, you need the three elements of that: osteoinduction, osteoconduction, and osteogenic modalities there. So let's go back to our patient. So this is, I know her. She's 80, diabetic, had this fracture, and you can see from the fracture fixation itself, it is insufficient. You can see there is a varus angulation at the fracture site. The proximal screws are backing out. This is insufficient. However, the critical factor I can see from the X-ray itself, it has neither the callus formation at the fracture site nor is the implant stable. So therefore, this probably comes in the second level of NUSS 25 to 50, where both biology is poor and stability is poor. So how do you go about this? Confirm there is no infection and then see what we did. So we have restored the mechanical stability with the locking plate, but see, we have used dual plating because that gives a three-dimensional stability at the fracture site. We have included the whole of the lateral pad. We have supported the stem at the top, and obviously we added bone graft. And she has recovered very well, fully independently mobile, and that probably should have been the first choice of treatment. So let's look at this one. This is a complex one. These are the x-rays I got from my friend, and I should thank him for it. So this is a lady who's 74, had a fracture nearly a couple of years back. The first figure is the one where they plated it, but she ended up in an emergency situation with the fracture on the first. So obviously you can see now that she has a broken plate, classical non-union, with a wound infection. So this is infective non-union, periprosthetic, distal to the stem. But when you try to go in and resect that bone part, you are left with a big void. So this void is significant. So how do you fill that? So the coming to the filling of this, you can see that this is a two-stage procedure where you have excised the infected bone, temporarily stabilized with a Kunsher nail sort of picture, and significant amount of antibiotic-laden cement. Antibiotic-loaded cement gives a significantly good elution of antibiotics at a local level, controls the infection. Luckily, the infective organism was trapped, therefore it worked very well. So that's the X-ray. Few weeks down the line, you can see there is some orientation of the fracture side, and this is the second stage. So this is a custom-made prosthesis, not available, I know, at all centers, but these are difficult fractures to treat. So you got a custom-made prosthesis with a proximal stem, where extension, where you can have the stem fitting in the custom-made implant itself, and then there is a flange on the outer side which is supporting the stem on the outer side. Distally, we managed to save the femoral condyle. But these are complex injuries, difficult to treat. But these are what I'm trying to say is a way of treating, understanding, and applying that for you. So if you are asked in a paper, okay, tell me a paper. So this is a mnemonic I have made. This is what the way. So it's PCOP. So this is a general information. If you guys need to say you are put on a spot, okay, tell me about a recent paper. So this is the way I go into say learning this. So this can be your template. Classically, if you look at it, it says the learning resources. But believe me, if you Google or PubMed, both Calorie and GeoNadis, you'll get most of the articles that you need to know on non-union. There are a couple of articles I have squeezed in there because I did masters in nuclear medicine, and therefore I have published a couple of them. Please have a look at it, and if you need any, please let me know. I can send it across, and probably that's where I will thank you all, guys.
Thank you. Thank you, Kartik. That was excellent, very useful talk. And I'm sure that everybody that's listening will have learned something, and some good tips for the exam as well as for your practice. So I've noticed there's a couple of questions which I've written down. So what I'm going to do now is I'm going to launch the MCQ. So there's just 3 MCQ questions. It's anonymous, so if you just answer them as soon as you can, and then we'll talk through the answers, and then we'll move on to the questions. So, okay, there we go. Just 3 questions. Okay, 1 person has answered as far as I can see. Oh, no, some more. All right, it's 2 minutes. So I'm going to end the poll and then Kartik's going to talk us through the answers. So thank you, everyone that's answered.
Right. Shall we take it on? So 100%. So let's look at the first one. If you look at the first one, this is what I put it up on my definition slide, isn't it? Definition of non-union FDA is a fracture which has taken at least 9 months old with no signs of radiological progression of healing, or a symptomatic fracture with no apparent potential to heal, or a fracture which has taken twice. So the first one is incorrect. Good, 70%, nearly 70% have answered correctly. That's a good number. So let's look at smoking and non-union. Correct. You got the key element that I pointed out, that smoking, remember twice, 2, 2, 2. So twice the more likely to develop non-union, tibia, and twice the number of in any fracture. So if you are asked for that, remember 2, 2, 2. Right, that's good. Let's off. Right, so NUSS score 30, yeah, they come into the second group. Remember where I suggested that you need mechanical and biological. So you revisit your mechanical stability, and then you have to enhance biology, isn't it? So what can you do? You can do the pulse electric magnetic field. Yes, 69. Antibiotic therapy has no role in the classification system of NUSS. Megaprosthesis, as we said, are for patients who are more than 75 in NUSS 4. They are patients who have significant comorbidities, type C host, and Mascale is required for group 3, where they're scoring between 50 to 75. So less than 0 to 25, stability, hypertrophic, predominantly union, so improve the stability. Biology is already there. 26 to 50, we need improved stability or better stability, and improve your improve the biology, which you can do with multiple levels. And then pulse electric magnetic, and the third one where you have a defect, infected non-union, and fourth is where it's more than. So someone put it on the chat, they wanted to know NUSS score again. Shall I go ahead, Nikki?
Yes, please.
So shall I show the slide? I don't know.
Yeah, if we can.
So I'll do take this poll off, and I will share the slide again. Right. 4 groups. Easy. 4 groups. So divide into 4 groups. How do you get to a score? With score is the slide before. So there are 3. This is a busy slide, I know, but each of the elements which are risk factors or predictors of non-union are given a score. In the end, all these are calculated, and you come to a core number. So when you come to a core number, you have a patient, say, okay, the patient has a score of anywhere between 0 to 25. So these patients traditionally have biology is good, but they have mechanical instability. So if you establish stability, then they are going to go to heal. Patients who are scoring between 26 to 50 have probably both a problem. So therefore, you integrate your mechanical stability, but enhance biology by various modes. You can use pulse electromagnetic field. You can use extra short wave corporal shock wave therapy. You can use biologics, anything that is possible. When you come to the third group, which are scoring between 51 to 75, these are more complex. Why more complex? These are probably patients who have infective non-union. These are patients who will develop a bone defect. And therefore, you are now landed up with a problem of infection plus bone defect. So you have to address all this. So how do you address this? Obviously, you need stability, but you need to organize things to heal by getting a bone defect healed up. So there are various techniques for this. So techniques can be Mascale, or induced membrane technique, which they have quoted nearly 80% healing of non-unions. Remember, even with all these techniques, nearly 20% of non-unions don't go on to heal. Then you have the newer modality called RIA system, well described in literature, again from Prof. and Leeds. Please have a look at it. And all this is called, so you have to get the three key biological elements of healing. That includes osteogenesis, osteoinduction, and osteoconduction. So that's why this all therapy is jointly called as polytherapy. And obviously, if the patient is scoring more than 75, it comes into the last group, where the host itself is in host C group, significant comorbidities, where any reconstructive surgery is going to be more detrimental than considering a salvage procedure. So did you all guys get that? I'll stop sharing.
Okay, Mohammed, I hope that helped. Mohammed had another question. I wasn't sure whether it was a question, Mohammed, or whether it was a statement. You've written why dual plating, distal femur LCP and bone graft would have done the job.
Yes, the thought process is both at distal and proximal. Subtrochanteric, the Liverpool concept is if you have a subtrochanteric non-union, traditionally use a nail to do a non-union, but they end up, nearly 20% end up in non-union. Liverpool has a low threshold dual plate. Why? Because plating, you can give you a good angular stability maybe in one plate. But subtrochanteric, the proximal fragment always tends to flex up. So if you have fixed it laterally, that tends. Therefore, they just put a neutralizing sort of picture so that you get integrity in four. The similar concept may be in the distal femur as well. See, remember that distal fragment in distal femur flexes, isn't it? Because the hamstring gastroc are attached there. So the gastroc pulls it down. So you get a lateral AP line stability with your lateral plating. But if you want to do it in the AP in the anteroposterior plane, probably dual plating. You may get away with a single plating, but that encompasses everything. You come out of it and it's going to be stable.
That's great. Thanks, Kartik. It's one of those I want to go to bed and don't call me operations. So, and then I've got a question from Norman. Norman has asked, what is the definition of delayed union?
So delayed union is any fracture which has taken longer than the traditional amount of time that it is required to heal and is at a risk of non-union. So delayed union can be anything. Say, for example, tibia, 3 to 4 months. So if it is taking and you are checking at 6 months, still not healing, but it's not at the time where it is becoming a non-union. Probably it may end up in healing in the next month. So that is delayed union. So traditionally, longer than normally it takes a fracture to heal, but not as long as a non-union. Non-union is a fracture where it won't heal. It's unlikely to heal without intervention. That could be intervention surgically or by non-surgical like pulse, electric, etc., etc.
Great. Thank you. I hope that answered your question, Norman. And Mohammed's got another question. What's the role of Alizarov in non-union? Is it a good device to address the non-unions?
Yes, very well established before the Mascale and newer techniques of RIA. But there is a limitation maybe on how much length you can achieve. Maybe say it is good, say, Drawer Palace article, it says about 8 to 15 centimeter. However, remember, all the distraction osteogenesis Eliza Rao have long rehabilitation. They have to wear that frame for ages. Lot of pin side problems. So therefore, patient's compliance is also difficult. But believe me, Eliza Rao, external fixator, ring fixator are a marvelous way of trying to heal, especially defect and infective and non-infective defect unions. We use that traditionally in India. Royal Liverpool has a very good Eliza Rao unit, and it requires a dedicated unit, a dedicated team, patient compliance. And remember, they do well with tibial fractures, not in femur. Femur is a no-no for Eliza Rao because lots of complications.
Thanks, Kartik. And I've got a question from Mohammed, a different Mohammed. Would you consider an IM nail and plate rather than dual plating?
Yes, but remember, if you are using two modalities of techniques, so IM nail is taking your endosteal blood supply off. Plating is taking your periosteal blood supply. I know there are fractures nowadays where they're advocating retrograde nailing and a stabilizing plate. Yes, you can. You need to get stabilization, whichever way. So if you are going down, you open the fracture site itself, lateral plating you have done, you simply put an anterior plate. You are there, aren't you? Otherwise, you go ahead with a different construct, different element. And remember that IM nail they had failed, isn't it? So once burnt, maybe use a different technique which works well in your hand. I think that's the way forward.
Thank you. Okay, one more question, and then we'll move on to Viva. So again, it's Mohammed. What's the protocol in UK to treat infected non-union?
It's a big subject. So all the regions have a dedicated limb recon unit. So that's where most of these patients do get. So DGS is difficult. So if you are in trouble, if you have scored, so NUSS system is to know a non-specialty clinic when to refer. So if you see a patient, you have fixed it, 6 months, 9 months down the line, you're scoring 25, 50, then you know you are heading for a non-union. Seek early advice from them. You can communicate with them. Listen, I have this. And they are very good at dealing with this because they have a system in place. So obviously, when they are seen in their clinic, they have a non-union clinics. You know, Royal Liverpool has a well-established non-union clinic every Friday. Go there. You'll see a spectrum of patients. They have a system of assessment. They have a system of imaging. They have a system of getting the organisms. It requires an MDT meeting. The microbiologists are involved because they have varied organisms. Some require more medical input because they are diabetic, unstable diabetes, etc. So you need an MDT approach. You need a limb recon unit. You need someone who does this regularly. You need an MDT input. You need to have a team of physiotherapists and rehab specialists to look after, because pin sites and looking after the frame is key element.
Thanks, Kartik. Yeah, I think, I'm not sure where you work, Mohammed, but I certainly work in a DDH and infected non-unions for us, or, infected joint replacements, everything seems to be a lot more centralized in the UK. So if you have any kind of problem, there's usually a regional centre that you can refer to, or at least discuss the cases with, and send over the radiographs and things. So for anyone that's doing the FRCS exam, a key thing to say in these questions is MDT approach, regional centre, and that will tick marks off for you, and it shows that you're safe. For the purposes of, well, if you're working in the UK, yes, but for the purposes of the exam, it's important that you say those things. Okay, that's great. So we finished the questions. I am going to stop the recording and we'll move on to the vivas.
Recording stopped.
Okay, fantastic. Great. So we're going to give you a rest for a case, Kartik. So David's going to do the first viva, and the first candidate I have is Norman Niazi. Norman, are you here?
Yeah.
Okay, great. So David is going to be your examiner. We'll give you 5 minutes. I'll be your second examiner, and then we'll give you some feedback.
Okay. So who's in the title? Okay. Can you see this, Norman?
Yeah.
Okay. So this is a 53-year-old lady who's presented to the practice clinic with a mid-sharp. Well, tell me what you see.
This is the radiograph of left humerus of an adult 53 years old lady, showing the displaced distal 1/3 humerus fracture, which is angulated laterally. And I want to know about the history of this patient. What is the mechanism of injury? When this happened? Was it open or closed injury? Was there any other injuries?
So it's a closed injury. It happened before she was walking a dog. She tripped over.
Okay. So she's in a fracture clinic. So I suppose she is stable. Otherwise, I want to know handedness, occupation, hobbies, and any other medical comorbidities, especially diabetes.
She's right-hand dominant. She works. She's 53. She still works as a teaching assistant in a classroom.
Okay, right.
No.
Right-hand dominant, and this is left side fractured. So this is a displaced fracture, and I suppose this happened a few days ago, and she has got
24 hours ago.
All right. Okay. Right. So the position is not very satisfactory. I want to examine this patient, especially I'm looking for the soft tissue envelope around the arm.
What at the moment?
Sorry.
What is she in at the moment? Is she in a?
She's in I think in a use lab.
So what's the first thing you're going to do?
I will remove the plaster, use lab, examine the skin underneath, and check the swelling compartment, and check the distal status, especially the radial nerve.
There is a little bit of altered sensation in the first web space. She doesn't have any obvious wrist drop, but she's very bruised and battered, but she's all soft. No sign of trauma syndrome.
Okay, so I will give her a use lab in a better position, and then I will repeat the X-rays to see the position, whether it is satisfactory position or not. My intention is to manage this patient non-operatively, because aware of the papers in which.
That's fine. So one of your colleagues saw the following day and felt, "Oh, I don't quite like this," and decided to do this. So tell me about this fixation.
This fracture has been managed by open reduction tunnel fixation it's looked like a recon plate to me.
Yeah, the recon plate. Yeah,
it's a recon plate, and the one of the screw is going through the fracture side, which is I'm not happy with that screw.
What are your concerns then about this type of fixation?
This
on the screw, and
they have tried to do the to achieve the interfragmentary compression with to achieve the primary bone healing, and which like alignment is fine, length has been achieved likely, but I think that one of the screw is going through the fracture side, which may hinder the healing process. But I will observe this patient. If she is doing well, then I will observe her and get the X-rays and get the wound check in a couple of weeks, and then I'll get X-rays in 6 weeks' time to see how she's.
She was followed up, yes, and then she was seen at the 6 month mark. Sorry, this was six. Sorry, that was the 6 month mark. So that was at 6 weeks.
Okay, right.
Yeah.
Right. So 6 months has been elapsed, and there is still a gap at the fracture site. First of all, I will rule out the infection. I will clinically I will check the wound, any swelling, redness, any sinus formation, and then I will check the biomechanically and chemically by checking and getting the bloods, FPC, CRP, UNAs, and check if there are signs of infection and after CRP.
So what is this? Is this 6 months after the injury? So what would you call this?
This is a non-union of the humerus fracture.
What type of what do you know? Any types of definition for non-union?
Non-union is by definition if there is 9 months have been passed and fracture has not shown the signs of union, then we call it a non-union, and it depends upon the type of bone and other factors as well. Like
5 minutes.
That's 5 minutes. Yeah.
Okay. Fine. Okay. So Norman, how do you think it went?
I should have gone quicker. I wasted, I think, time initially. I should have.
You spent too much time on the opener for 10.
Yeah.
I wanted to get to this very quickly. This is where the meat of the question was. Talking about non-union. Okay. But now we've got a bit more time. So this is at 6 weeks. Is there an issue with this fixation? You mentioned about that screw and the type of fixation. What type of fixation is this?
This is a rigid fixation.
Rigid or absolute?
To get the absolute stability with rigid fixation.
Yeah. And what's the critical issue with this that you notice on this fixation? It's supposed to be at 6 weeks, remember.
One of the screw is going through the fracture side, should not have.
One screw is fracture side. And what can you see at the fracture site?
There's still a gap there.
Yeah, still a gap, isn't there?
Yeah.
Yeah. I mean, the gap looks like it's obliterated here, but it was too rigidly fixed, wasn't it? And what's the first stage of bone healing? What's the first cells that start acting in bone healing?
Osteoblast.
Osteoclast. They eat all the dead bone, don't they? That's why we take pictures. We take X-rays of scaphoid fractures in 2 weeks, because hopefully the osteoclasts have made the fracture more obvious for us. Yeah.
Yeah.
So yeah, you're right. So you need to quite right. You need to rule out an infective cause for non-union in this situation. But this is an example of where you have too rigid a fixation. You've got too big a gap, so you have atrophic, don't you? There's no
right.
Yeah. There's no excessive amounts of bone here. You can get atrophic in not an infective causes, but it's normally hypertrophic because it's throwing up all over the place, isn't it? But you're right. You need to rule out infection and everything, and then you need to think about how you're gonna treat this. Out of time now, but how would you approach this now?
So there's a problem with the mechanics over here, not the biology.
Yeah.
So I will redo it by using the. I will use the bone graft because it's going to non-union, and then I will get the interfragmentary compression by using the locking plate.
Locking or compression plate?
Compression plate, sorry.
Okay, yeah.
Okay.
Which is what they tried to do here, bone graft, compression. But there was also a little biology as well, because she's a smoker. Always ask about smoking. But yeah, so they did that. Unfortunately, with the biology, that happened. Okay. But you're quite right. I do agree with you. First instance, I wouldn't touch it. I wouldn't try to fix this. You're right in the first instance, by the way. You try and treat these non-operatively, not necessarily in a collaring in a use lab, maybe a collar and cuff or even a humeral brace. But the concern was a radial nerve palsy. Is any evidence for rushing in to fix things with radial nerve palsy?
The paper from Shao et al. Meta-analysis, they have in 2005, and they have mentioned that and we should manage it expectedly instead of intervene for if there is any radial nerve injury, and 85% to 90% recover.
Exactly. So this is an example of the all-star idea. If there's a radial nerve palsy, we need to do something about it. No, you're quite right. 85% recover. So this is why the title is Getting It Right First Time. Okay, cool. Excellent. But just work on your approach. Get that. You need to speed up a bit. The opener for 10 is about just relaxing you, and you say, right. So you want to say non-operative management, but I want to double check a few things about the patient first, which you did, but you took a little bit too long to get there because we wanted to talk about non-union, didn't we? Right. But it's fine. It's fine. I know you know the stuff, but we're just going to move, we're going to make you a bit more efficient in your getting to the meat of the question. All right?
Thanks.
Okay, well done, Norman. All right, so the next candidate is Elashmi. Elashmi, are you there? Elashmi Kablan, did you want a Viva? Yeah. Okay, great. If you want to turn your camera on and your microphone on, Mr. Iyengar is going to ask you a question. There we go. All right, I think David.
Yes.
Yeah. David, can you be second examiner? And when you start, Kartik, I'll start timing.
Right. Shall I share my slides? Do you have it there? Let me find that. Just bear with. Right. Can you see my screen?
Yes, I see.
Elashmi, this is a 55-year-old lady, quite fit and well, dog walking.
There is no picture on the screen.
Okay, let me show.
I think you need to start the presentation. Sorry, Mr. Iyengar.
Right. Can you see it better?
No, we can just see.
Okay, let me start again.
Yeah.
Yes, now we can see it.
Right. So Elashmi, this is a 55-year-old lady, fell dog walking, fit and well. You see her in the A&E. She has no comorbidities. So what are your thought process?
What? I don't.
So this is a 55-year-old lady.
Yes.
She fell dog walking.
Mm-hmm.
She has no comorbidities. You are seeing her in the A&E. Those are the first X-rays in the A&E. What are your thought process? How are you going to proceed?
Yes. First, to check its patient is okay, and there is any other.
So this is the isolated injury.
Isolated injury. Okay. This is an X-ray of a mature patient. There is a fracture in the hair ankle extend to the interarticular extension and the posterior malleus of the hair ankle.
Okay. What would you like? Anything else?
I want to check the neurovascular and swelling.
Yeah,
and
they are all fine. Neurovascular intact.
Injury or open wounds.
No open wounds. It's a closed injury.
Mm-hmm. And neurovascular examination.
Intact.
and there is no swelling or blisters.
No.
I will start to put her in the slab.
Yeah.
Resting slab.
Yeah. Everything done. BT prophylaxis given. What else? What are you going to send her home?
Check a joint above. So check the knee.
No,
and,
that's fine. Knee is fine. Only isolated injury. Are you going to send her home or do you plan anything?
I will send her to home.
Okay. And what is the follow-up after that?
And the follow-up, I will check if the sign of union, if there is any displacement happen. You can proceed then with complete cast.
Is it? Okay. So when are you going to call her back in the clinic? Next week, week after?
Next week, yes.
Okay. And what are you going to do next week?
If there is a new X-rays.
Okay. The check X-ray again shows the same picture. What are you going to do?
Same picture, a complete cast.
Is it? But are you missing something here? So what is the configuration of the fracture?
There is a fracture in the posterior malleus of the tibia.
Correct. So if you have a posterior malleus fracture, how do you assess a posterior malleus?
I want to check with syndesmosis.
Okay. Number one. Number two, what are the criteria of assessing a posterior malleus fracture? Is there a classification that you approach with? Is there any additional anything would you like to know?
Yes, you can do CT scan for additional modality to check if there is displacement or articular step-off.
Very good. So when are you going to check that? So do you want a CT now? Okay, that's the CT. What do you think?
There is posterior malleus and there is a fracture in the lateral malleus also.
So when would you organize the CT? When you see in the fracture clinic or a couple of weeks down the line or 6 weeks down the line?
La, in the clinic. In
the clinic. Okay.
Yes.
So what do you see here? Describe the fracture. Tell me the configuration. Tell me the classification.
This is a
Are you aware of any classification for posterior malleus?
Yes, there is a Lig-Hansen classification. This is classified the bimalleolar fracture, and this is.
That's 5 minutes.
Anything else, Lashmi?
So supination, external rotation, and the Lig-Hansen classification.
Okay. I think we need to stop. 5 minutes have passed. What do you think? How have you done?
What?
How did you think you did?
Not very good.
No. Need to work a bit more. Need to get a bit more fluent. We should be, when we are nearly at 4 minutes, you should be at the management point. You should be at the complication point. We are still with the patient in the fracture clinic. Okay. So the thought process has to improve. Okay. Let me start here. Okay. Let's go back to the slide. So this is a fit and well patient. So we have looked at the risk factors, not diabetic, not smoker. She walks a dog. So she is fit and well. Okay. That's the key point in the history. Examination, no blisters, nothing. Now X-rays. So X-rays, there is a classical telltale sign which you should pick up on this X-ray. Can you see the double shadow here? that
Yes.
is suggestive of a more than a simple sliver of posterior malleolus. Okay, there you can see, and here it is also a big chunk there. So if you go to the traditional posterior malleolus classification, they say 1/3 of the articular surface, 25%. That has been superseded by a new, which is recent classification for posterior malleolus called Mason-Malloy classification. So when you go home today, pick up Mason-Malloy, Google it, and start reading that, please. Because now the management of posterior malleolus is in the limelight, because there is a classification system which is validated, and Royal Liverpool entry, it comes from entry, they have validated results depending and managing a fracture like this, and they have made an algorithm, and they have proven that if they follow their algorithm, they have a classification system which gives predictable good results. Because traditionally posterior malleolus was said, oh, it will get better. No, there is a significance applied to that. Okay, so that's
Okay.
so if you go on to the Malloy classification, I have missed a slide. Okay, so that's the classification. So Malloy, Mason-Malloy classifies posterior malleolus ankle fractures into 4. 1, where there is only a sliver of bone. 2A, when there you have a posterolateral posterior malleolus component. 2B, where you have a posterolateral medial component of the posterior malleolus. And 3, where there is a predominant medial component of that. And they have, so if you go on to this picture, that's the final one. There, that's what the classification is. So if you look at the Mason one, you only have a sliver. So you fix the syndesmosis, you should be fine. 2A is the component where you have a posterolateral chunk. Can you see that? So you need to fix that posterolateral and fix your fibula as well. 2B is where your posterior malleolus has 2 chunks, posterolateral and posterior medial, most unstable. So you need to address all of this. And the third is looks like a bit simpler, but it is more like a play-form fracture. You know, it's taken a large chunk. So you have to address that differently. And they have created an algorithm to teach how to fix this, considering the whole ankle fracture itself. So if you have a type 1, you fix the syndesmosis. If you have a type 2A, then you go by posterolateral approach, fix the posterolateral component, and deal that fibula in the same approach. We can do that. However, if it is both, then you have to address posteromedial, take one incision because you have to leave a space, isn't it? And then address the fibula with a separate incision. If you have a 3, then your main incision is posteromedial medial. Go from medial, fix the posteromedial component, and come back if you need to come back for your fibula. What they have tried to find is if you fix the posterior malleolus well, then there is less likely that you need a syndesmotic screw to go as well. So if you fix the posterior malleolus well, reduce it well, and check the syndesmosis, they are quite stable. So did you get that? So please look at this paper. This is what we did. So you can see we address both the posterolateral component, posterior medial component of the posterior malleolus, and fix the fibula separately. Okay? That okay, Lasmi?
Okay. Now, El Hashmi, may I ask, when you're doing the exam? Have you got a date for it? Hello, El Hashmi, you're not frozen, have you?
Looks frozen, I think.
Okay. No, he's gone. I forget. Fine.
Okay, I'll stop sharing.
Yeah.
Stop sharing.
Okay. Well,
Oh,
I guess all we can do. I was going to thank the 2 candidates for put themselves forward for a Viva. It's always quite stressful, but it's better to make a mistake in this environment than it is in the actual exam. We've all been there. We know how it feels, but it's the best practice that you can get. So thank you, everyone. The other people I wanted to thank was the people that put the questions. I thought we had some really good questions for the lecturer. And yeah, I certainly learned something this evening. So I'm very grateful, Kartik. That was a really good lecture and very, very pertinent to the exams as well as, you know, our general orthopedic practice. So I guess all I've got left to do is just remind you that we'll send some feedback forms. If you can fill them in, and also we can provide certificates. We've got some upcoming courses, the intensive mock Viva course, and then we've got our case-based discussions course and the basic science courses. You can book and see what they involve on our website, www.orthopedicacademy.co.uk. And yeah, the other thing is, that's it. I'd like to thank my fellow faculty for this evening, and I wish you all a good night. So if the candidates would like to sign out, and if David and Kartik just stay for 2 minutes and we'll wrap up. So I'll get you all to sign out. Thank you very much.
Sorry, gents, if you can sign out, I was going to put you in the waiting room.
Okay. So I've just got put everyone in the waiting room. There we go. Is that it? I think is Ashok gone? He must have left. Yeah, I thought that was really good. Thanks, Kartik. That was excellent.
Sorry, I missed the beginning, but when I got to the end, that was very good.
Yeah, I enjoyed it.
Yeah.
That was my table last month, fracturing and non-union basic science. And we are having one more next in Jan. So I'll use the same slides.
Yeah. No, it's great. If you want to join any of our faculty courses, I can send you some details.
Yeah, please do. File free, I'll do that. I'm cow in December, about 7 days, 10 days. And then a couple of commitments in January, but otherwise fine. So cow, we do a week off on call. So that
yeah. All right. Well, thank you very much for this evening, guys.
Yeah,
it was lovely. And have a good evening.
You too. Thank you.
Right.
Hi, David. Nice to meet you.
Nice to meet you too. Right.